So we are going to kind of go over understanding what those sleep disturbances are, how often they occur, maybe some things that we should be looking out for, how we address those, and maybe some other things that might either that those sleep wake disturbances might be impacting or that might be impacting the sleep wake disturbances. So we're going to talk about a couple other things towards the end, where we're going to talk about some hormone dysfunction as well as gut microbiome dysfunction. Okay, so let's just get started with, obviously we all have heard about 1,000,000 times, I'm sure, that sleep is good for us, right? Some of us do better at listening about getting good, healthy sleep than others. I know I'm guilty of do as I say, not as I do necessarily. There's just so many things to do during the day. Who has time to sleep? But it is so, so important, especially when healing from a brain injury, that we're getting that proper sleep. And we'll talk about what that word proper sleep is referring to, right? So it's important for cognition, the way that our brain functions. It's important for our immune system health. If we're not sleeping well, we're going to get sick. Emotional well-being. I mean, who's even before brain injury, who's gone into work or around people and you didn't get enough sleep and you're grouchy, right? So it's important for our emotional well-being, just our general health, right? So anytime we have impaired sleep, we're not getting enough sleep. Our sleep is really fragmented and broken up during the night. It's going to, again, lead to increases in poor health. So we're going to get colds, we can catch viruses more easily. It's also going to lead to increases in inflammation in the brain, impaired attention. So no matter how much rehab you're getting, if you're not getting sleep, your brain can't respond to that rehabilitation in the way that it needs to in order for you to get better. Okay, so human and animal studies have both shown so much evidence that there are sleep-wake disturbances after brain injury, and that the prevalence of those sleep-wake disturbances is much, much higher post-brain injury than in the general population. So yes, they exist post-brain injury, and they are more common than in the general population. Okay, in fact, up to 80% of brain injury patients have sleep-wake disturbances. So I stress this all the time in anytime I'm speaking to in a rehab environment. I'm speaking to those clinicians, the therapists, reminding them that nearly every single brain injury patient that they see that day is going to have some sort of sleep-wake disturbance. Now, sometimes I feel like we all in general tend to tunnel vision. When we hear sleep-wake disturbances, we tend to think of certain things, right? And one of those big things is sleep apnea. And yes, that is way more common after brain injury than in the general population. However, those sleep disturbances are multiple. They are multifaceted. We got a lot of stuff going on. Just because you have one thing going on with your sleep doesn't mean you also don't have something else going on with sleep. So it's really important that not only are we checking out sleep, if you've had a brain injury, check out the sleep. Even if you feel like you don't necessarily subjectively feel like there's anything wrong with their sleep, which I feel like most patients will say that they have problems sleeping. But even if they don't, especially in those more acute settings where it seems a little bit more logical that somebody's going to have trouble sleeping, and say, oh, well, of course you have trouble sleeping. You're in a hospital. They're turning on the lights. They're checking your vitals, doing all of these things that would be disrupting sleep. But it may be even more than that. So it's important to address those sleep-wake disturbances and not only, again, kind of focus on one thing, but being able to get that full picture if we can. And that's those in-lab sleep studies that are going to tell us the best information that we'll talk about. I'll show you what that looks like. So not only do we have that sleep disordered breathing or sleep apnea, but restless leg syndrome is extremely common after brain injury. Excessive daytime sleepiness that doesn't necessarily relate to or correspond with sleep apnea. So one of the biggest symptoms of sleep apnea is that daytime sleepiness, but you can be really heavily sleepy during the day, have a sleep study, and not have sleep apnea. So then what else is going on? And it could be due to damage to a particular part of the brain that controls those transitions between sleep. It could be because of a medication that you're on. So knowing all of these things and being able to advocate for yourself too can be really, really important. Okay, so I'm going to get a little sciencey for the next couple of slides because I feel like it's so important for patients and family members to really understand what's going on, at least surface level, during sleep and what might be going on, right? So sleep is not a passive process. You hear, oh, I'm going to go to sleep, I'm going to get so much rest. And yes, this is true. Your body's resting. To an extent, your brain is resting, but there's also so many things going on in your brain. A lot of complex chemical signals that are telling which parts of the brain to do what, so that we can get that restful sleep, but also consolidate memories, and work on some of those things that we did during rehabilitation, or even if we're not in rehab, just normal general sleep. That sleep gives us time to get rid of all of the junk throughout the day that didn't really matter, to hold on to the stuff that was important, and then again get that restful sleep that your brain needs to also be able to control other bodily functions. Sleep looks kind of crazy when you look at a patient that's sleeping and you can see what their brain activity looks like. It's all over the place, right? So that little spot up at the top, the line up at the top there, shows you what an awake brain, the brain signals look like, what it looks like during non-REM sleep. Non-REM sleep is that part of sleep where your neurons are your brain cells are kind of firing at the same time. So you're having this really high amplitude, really kind of slow waves that are going on where we're getting that restful sleep. But then during REM sleep, you can see that it looks a lot like an awake brain. So you're dreaming, your brain is kind of consolidating some of those memories and really working really hard on attention and concentration for what we're going to be doing the next day. So again, there are distinct phases that we can see during an EEG or an in-lab sleep study. All of them look different. All of the waves look different. And each one of those waves not only corresponds to a different stage of sleep, but corresponds to what the brain is doing during that stage of sleep. So it's a very complex process. And a lot of stuff is going on all at one time. So we kind of need all of those things to be functioning properly for our brain to be giving the correct signals in order for us to be having that proper or healthy sleep, right? So you can imagine that after a brain injury and we've injured part of the brain, how difficult it would be for this complex process to happen on its own like it would normally. So this is what an in-lab sleep study is going to look like, okay? This is kind of the gold standard for addressing sleep-wake disturbances. Whether you've had a brain injury or not, the in-lab sleep tests are definitely the way to go if you can get one. Now, I said that sleep is not a passive process, so there's a whole lot of stuff going on simultaneously, but it's very, very organized. Okay, it seems like this chaotic mess, but it's very organized when it's healthy. When your brain is healthy and it's doing what it needs to do, those sleep stages happen in the same way, at the same time, for the same length of time for everybody, with minor tweaks here and there for as you age. It changes slightly. Men and women are different a little bit, but for the most part, that sleep cycle happens in the same way for everybody. So we know that it's a very important process when it's, maintained throughout generations, through genders and things like that. So again, those stages can be seen during these polysomnographies. So not only do we have the EEG that is attached to the brain, or to the scalp, that's going to correspond to what different parts of the brain are doing. So we've got some electrodes on the head, but we're also going to have that nasal sensor that sits right under the nose that's going to be able to measure oxygen flow. And then those elastic belts on the chest and the abdomen are going to be able to check whether or not you're having apneas, whether we're not breathing properly during sleep. And then we also have sensors on the legs to check for restless leg syndrome. So you're kind of hooked up to a whole lot of stuff. So I say it's the gold standard. If you can get one, that is the best way to go to really be able to address everything all at once, but it can be a little cumbersome. I've had one done, testing some equipment. I don't like to talk to people about doing stuff that I haven't already done to myself. So I have had one, and it is a little bit different trying to sleep with all of that stuff going on. And you're also in a different environment, which can be hard to sleep in anyway, you know, sleeping in your own bed versus sleeping in a hotel room. So it can be a little bit difficult, but usually sleep labs will put a whole lot of things in place for you to feel as comfortable as possible. So bringing your own bedding or pillows or whatever to be able to make you as comfortable as possible during that process. So I said it's very, very organized. And part of that is based on neurochemical signals in the brain. So the types of signals that one brain cell is sending to another. They are very complex. Each state is characterized by very distinct firing patterns of the neurons. So during stages of sleep, certain neurons will fire and then they stop firing or slow down and other ones start. So that's how your brain knows to kind of transition between different sleep stages. And obviously I won't go through all of those neurons and what they're doing at once, but I like this picture because it shows how those different signals are telling other ones what to do, right? So during that REM sleep, that those green bars, if you look at the green bars that are spread throughout there, the red signal is going to signal REM to start. And then once we've had enough REM, those are going to slow down. And the blue cells, the REM off cells that signal the other stages of sleep, are going to pick up. So it's this very coordinated attack of different neurons telling your brain to do different things. So what that ultimately leads to are these sleep cycles that we have during sleep. And again, these happen almost identically in every person, right? So the sleep architecture or the way those sleep stages are put together is very important for being able to learn and remember and recall information, to respond to rehabilitation, to have everything firing on all cylinders, if you will. So during the cycle of sleep, usually we go through about 4 to 6 of those sleep cycles every single night. Each one of them lasts anywhere from 90 to 120 minutes, usually. And that cycle is that fluctuation between stage 1, stage 2, stage 3, and REM, and then back down. So you'll notice that these red circles indicating stage 3, that N3, that is the deepest stage of sleep. That is the relaxing part of sleep. That starts out really long at the beginning of the night. As the night progresses, it gets shorter and shorter until it basically disappears for most individuals. REM, on the other hand, is going to kind of do the opposite, right? It starts off really short in the beginning of the night, and as the night progresses, the REM sleep gets longer and longer and longer. Now, if we're only sleeping for about 3 hours, and we're supposed to go through 4 to 6 of those 90 to 120 minute cycles, it's easy to see how just not getting enough amount of sleep can impact that sleep architecture, because you're not getting to the point of sleep in night where you're really having a lot of REM. You're having too much of that deep sleep, not enough of REM sleep. So even if your sleep cycles were put together perfectly still, just by not having enough length of time of sleep, you're already impacting what those stages are able to do. Okay, so the brain injuries themselves. So how does the brain injury impact sleep? It can do it through a number of different ways. So maybe the most obvious is that there's the potential that we have a primary impact of damage to the sleep-wake circuitry in the brain. The stuff that makes our brain do what it needs to do during sleep, those parts of the brain can be damaged, right? Additionally, what are some secondary impacts of brain injury? Depression, anxiety, pain. All three of those things in a person without a brain injury impact their sleep, right? So depression impacts sleep regardless of a brain injury. Pain impacts sleep regardless of a brain injury. So does anxiety. So the fact that these usually go hand in hand with having a brain injury, that's going to impact our sleep. Now, our sleep-wake disturbances could be primarily due to the depression, anxiety, pain, or it could just be making it worse. Same thing with medications, right? So brain injuries also go hand in hand with a lot of different medications. A lot of different medications that were put on after a brain injury: antidepressants, antipsychotics, opiates, sedatives, stimulants. Any of those impact sleep. Again, regardless of a brain injury, that's a side effect of these medications. Now, after a brain injury, we're usually on multiple medications like this. Sometimes even we have to be aware of what we call polypharmacy, where we may be on multiple medications that really kind of do the same thing. And because of that, they're having way bigger impacts on our things like sleep, because we're on multiple medications, right, that are essentially getting at the same thing. So the more we can reduce medications and kind of have a physician really monitor those, stay consistent with your physicians, making sure if we're switching physicians that we're telling them all of the medications that we're taking so that we can really minimize that, that's going to help to minimize the effect on our sleep-wake disturbances. We're going to talk a little bit about sleep apnea specifically because it is just so common after brain injury. Now, a lot of people know that it's really common after stroke, but I feel like less people are understand how common it is after a traumatic brain injury. Okay, so they don't necessarily think sleep apnea TBI as much as they think sleep apnea and stroke kind of go together. So what sleep apnea essentially is a cessation of airflow due to the collapse of the upper airways. And now that is for at least 10 seconds. So imagine if somebody's telling you that you have apneas, no matter how many times they tell you what your index score is, it's based on an index score. So how many times per hour? That's for at least 10 seconds that you're not breathing, right? And a hypopnea is a partial reduction in airflow. So it's not the complete collapse. So typically sleep apnea is given to you in what's called an AHI, or an apnea hypopnea index. So that's per hour. How many times did your airways completely collapse? How many times did they partially collapse? And then that's given to you in a number per hour. So if you have an AHI of 123, and that's not uncommon, especially in stroke where it gets that high, that means 123 times within that hour you had either a complete or a partial reduction in airflow, right? So that's significant, okay? It's considered severe sleep apnea if you have an AHI of equal to or more than 30 times per hour. Very frequently, I see that number over 100. Okay, so mild sleep apnea would be between 5 and 13. Moderate's going to be 13 to 30, or 15 to 30. And then severe is going to be over 30. Okay, so not only do we have that obstructive sleep apnea that can be a problem, but also central sleep apnea and mixed sleep apnea. So central sleep apnea is more like your brain isn't giving your airways the proper signals, okay? Rather than having an actual obstruction, it's that your brain's not telling your airways what to do properly. And mixed is kind of a mixture of both of those. So the apnea-hypopnea index is really important to really understand what that means and really grasp what that means in the context of sleeping and not breathing, and how that might impact or how it does impact oxygen flow to the brain, and what that could ultimately mean for secondary strokes. Even after a brain injury, a TB, or after a TBI, if you have those sleep apneas, it can lead you at risk for stroke. Okay. So the most common presentation is, like we mentioned at the very beginning, excessive daytime sleepiness. So just being so tired, no matter how many hours of sleep that you think you're getting. Okay. Nighttime symptoms tend to be, having a hard time going to sleep, snoring, irregular breathing, shortness of breath. But we can also have daytime sleep symptoms as well. So if you're waking up with headaches frequently, again, having that fatigue, the excessive daytime sleepiness, having a really hard time with attention and memory. What can make this difficult is that there is a non-specificity of symptoms. So those symptoms look very, very different for everybody. Most people attribute snoring to sleep apnea, but that is not always, they don't always go hand in hand. It's a good indicator usually. However, I've seen countless patients never snored a day in their life and have severe sleep apnea. On the other hand, I've also seen patients who snore like a freight train and don't have sleep apnea. So we have to be careful about using these tried and true symptoms as that tried and true, right? They fluctuate for everyone. Okay, so the prevalence rate for sleep apnea in the general population is about 9 to 15% for men, and about 4 to 9% for women. This is at least as common as diabetes and asthma in the adult population, but it doesn't get talked about nearly as much as diabetes and asthma. Now, sleep apnea is on its own, regardless of any other types of comorbidities or kind of disease processes that happen, on its own is a significant risk factor for stroke. So it's especially common in stroke patients, where we have about 50 to 70% of stroke patients having sleep apnea. It could contribute to stroke risk, or it could have contributed to that initial stroke, or it could have developed after the initial stroke and lead to risk for secondary stroke. So we know that it's important. Now for TBI, again, you don't necessarily see that knowledge of correlation between TBI and sleep apnea, but the rate that we've seen is about 35 to 40% for TBI. Now that doesn't mean that those TBI patients have high BMI, a history of stroke, cardiovascular disease, diabetes, hypertension, any of those types of things. They don't necessarily have any of those symptoms or comorbidities, and yet they still have a prevalence rate between 35 and 40%. So it's still very, very high for them. Not as high as stroke, but still very, very high. Now, how? I get that question all the time. Well, how does sleep apnea contribute to stroke risk? And it has to do with oxygen flow to the brain, right? So a large proportion of patients that have ischemic strokes, where we have that cutoff of oxygen supply to the brain, they have their symptoms either right when they're waking up, or the onset is during sleep. So that right there gives us an indication that something is going on that kind of contributes to that stroke. Of those that were awake, most of them were during very, very early morning hours. Sleep on its own impacts blood flow in the brain. Remember when I was showing all those pictures about these complex signals that are going on during sleep and all this stuff that's happening simultaneously? Well, one of those things is changes in blood flow. So sleep just impacts the way that our blood flows. It doesn't necessarily mean that it's doing anything bad. It just is changing as we sleep. Age is also going to impact blood flow in the brain. It reduces by about 20% as we age. So that right there also is going to impact it. So what that means is that we have this age-related decline in blood flow combined with alterations in blood flow during sleep these things may kind of predispose the brain to compromised blood flow as we sleep. So as we age, which stroke is more common as we age, and then just as we sleep, our brain may be a little bit compromised. So what happens when we have sleep apnea and we tack on the sleep apnea aspect, we're having a significant fluctuation in blood flow during and after the apneas themselves. So age is affecting blood flow, sleep is affecting blood flow, the apneas are affecting blood flow. So if we put all of that together, it means that the brain's kind of automatic ability to regulate the blood flow in the brain probably isn't sufficient enough to kind of adjust itself to those rapid changes that are happening with the apneas. It can kind of handle the changes during sleep. It can handle the changes as we age, but you add that apnea and now our brain's automatic abilities aren't enough. So we need to kind of compensate for that using like a CPAP or a BiPAP to kind of help us out. Okay, regardless of sleep apnea, so we're going to kind of put sleep apnea on a little table for now. Regardless of whether or not you have sleep apnea, the sleep architecture, I put this picture back up there up on the top, regardless of that, the sleep architecture, the way our sleep stages are put together is disrupted after a brain injury. We tend to have less total sleep time, lower sleep efficiency. So that means like the amount of time that we're actually asleep when we're sleeping rather than kind of waking up in the middle of the night. We have reduced slow wave sleep, which is that really deep restorative stage of sleep, the parts that are circled in red on the picture there. We have a lot less of that and increases in sleep latency. And what that means is just the amount of time it takes us to go to sleep. So we kind of lay in bed, twiddling our thumbs for a really, really long time before we're actually able to fall asleep. And what does that do? That ultimately decreases total sleep time, right? So it's this kind of vicious cycle. The brain injured patients tend to have really fragmented sleep, increased wakefulness, and a reduced amount of restorative sleep. So all of that stuff above, that's what that essentially means. And that fragmentation, that fragmented structure in the sleep architecture is associated with problems with learning and memory, especially with recall. So underneath of the picture of the normal sleep architecture up top here, I have some examples listed for what sleep tends to look like for a couple. I picked a couple of stroke patients and a couple of TBI patients. So the top two are stroke. The top one is a male that was 57 years old and he was about 60 days post-stroke. Now, if we look at the picture, stage 3 sleep, the red circles up there, is supposed to be that turquoise color, the teal turquoise color. It's non-existent in that first picture. Absolutely 0 minutes of time of sleep were spent in that deep restorative stage of sleep. Okay, and then if we look at the REM sleep, which is the pink with the pink bars with the black on top, that's our REM sleep. Now that's supposed to increase as the night goes on, but really he's only got 2 REM and they're very, very long, right? If we go down to the second one, this is a 62-year-old female that was about 80 days post-stroke. It's very, very hard to see. However, I don't know if you guys can see my mouse. Can you guys see my mouse?
Yes.
Wiggling around? Perfect. Okay, so there's a teeny bit of turquoise here, a teeny bit here, but still definitely does not look like it does up here. This person only had really 2 cycles of REM sleep. Times that the patient woke up during sleep. Now, that doesn't mean that they were conscious of waking up, because usually it was, very short periods of time, right? So they're probably not even conscious of that waking up, but it's so fragmented that they're not able to, those brain signals aren't able to kind of complete their job during those stages of sleep because you're popping out of sleep all the time. Now let's transition a little bit to post-TBI. We look at this third one. We've got a little bit more turquoise in both of these for stage 3 sleep, but it's kind of all over the place. And again, extremely fragmented. Same thing with the REM sleep. And this is a male and a female. This was a 59-year-old male that was almost a year post TBI. And this was a 20-year-old female that's 155 days post TBI. So really wanted to emphasize here that this is a 20-year-old, right? We should definitely not be having any age-related issues with sleep. It should look a lot more like this. Whereas the other 3, you could argue maybe that age is a little bit involved in that. But this is a 20-year-old female, and this is not uncommon for what we see in younger folks with either TBIs or strokes. So the point I'm trying to make here is that regardless of whether those sleep disturbances come before the injury and contribute to the injury itself or result from it, they are associated with poor outcomes. Because, I mean, just imagine, again, somebody without a brain injury going to work or going about their daily activities with not enough sleep, right? We're having memory problems. We're unable to focus. We're grouchy. We have emotional issues. These are already problems for brain injury patients. So when we tack on these sleep-wake disturbances, we can't reach that maximum possible outcome potential. So secondary influences on sleep-wake disturbances. So we know that the brain injury can contribute itself. So I want to kind of take a step backwards to what I mentioned a little bit at the beginning of what could be making it worse. So brain injury patients, again, higher depression rates, higher anxiety rates. This is in comparison to what we call controls or patients with people without brain injuries. So that depression and anxiety are likely to contribute. They could be a primary problem for the sleep-wake disturbances. So maybe it's not that those areas of the brain are necessarily damaged, but just because of the depression and anxiety, we're having those sleep-wake disturbances. We also, again, can see those similar disturbances in depressed individuals that do not have brain injuries. So we see a lot of that same disruption in the sleep architecture. The treatment, again, also a problem. I mentioned the polypharmacy before. So again, we really need to be careful about those medications. Now, obviously, there's not necessarily an ability in all cases to take some of those medications off. Minimizing the medications is good. If we're on 2 medications that do essentially the same thing, can we have a conversation about decreasing one of them or taking one of them off? Or maybe potentially there are 2, if we know we have sleep disturbances, if there are 2 medications that essentially do the same thing, but one of them has less of an impact on sleep as a secondary side effect, then maybe you go with that one instead. So having those conversations with the physicians about your sleep in relation to medication is really important too. We can also look at the severity, the chronicity, so how long has it been? Really, it's important to know that these sleep-wake disturbances can pop up kind of anytime, right? So they may be very common at the beginning and kind of subside. They may not be as big of a problem in the beginning, but then they get worse as time goes on. So always paying attention and monitoring those and talking to your doctors about any changes can put you on a good road to getting those addressed. And really it can happen with any injury severity too. It's not like only severe injuries have sleep-wake disturbances. Those mild, quote unquote mild, I don't like the words mild, moderate, and severe, but even those mild concussions tend to come with pretty significant sleep-wake disturbances, even if they're kind of transitory, where they kind of are there and then they get better, and then they're there and then they get better. Aging is also something that we need to be considering as well, is that sleep-wake disturbances kind of increase as we age anyway. So even if we don't feel like we're having them now, having that conversation about how does aging contribute to that, especially maybe if we had a stroke, and being mindful of kind of how those work together for risk factor. And BMI and gender are also another thing to consider. higher BMIs, a higher likelihood of things like sleep apnea. We have more of a risk for sleep apnea with men than with women. However, because of that non-specificity of symptoms, women not maybe thinking that they have sleep apnea, it may be underdiagnosed in women. Okay, so I want to talk to you guys really quick about a couple of research studies that we have done in-house at the Center for Neuroskills. So again, we have that in-lab sleep study that our patients are able to kind of go down at our residence, have an overnight sleep study, and kind of go back to their apartment the next day. And we published 2 studies involving stroke, and we've got one on TBI so far. So the first one that we did is we wanted to see if there was a really big difference in hemorrhagic stroke versus ischemic stroke when we look at it in the context of sleep apnea, right? Because this could ultimately hopefully the idea is to give us that ability to advocate for which patients should be having these in-lab studies. Because even though it seems like it would be obvious to screen everybody, it's not always possible. So when is it most important to screen these patients? So what we found in this study is that we had a significant number of significantly more arousals in those ischemic. Their microarousal index, so the amount of times that they woke up, so that fragmentation of their sleep was again much, much higher in the ischemic stroke patients than in the hemorrhagic stroke patients. The next thing we saw was the apneas, right? So the apnea, hypopnea events, the index, much, much higher, significantly higher in the ischemic stroke patients. Now, obviously, when we look at these, that we're still reaching significant numbers in the hemorrhagic stroke patients. Now, these are number of events, not necessarily the index here in this particular graph. But again, it's much more prevalent in the ischemic stroke patients. So being able to utilize studies like this in a clinical setting to help advocate for when it's most important that we're looking at these. It's important all the time, but making sure that we are at least advocating for that structure of getting these things assessed in the clinical setting. Especially since typically, like I said at the very beginning of the talk, that it seems kind of obvious that at first patients are going to have problems sleeping with being woke up for vitals, with the lights coming on, being in a strange place, you just had an injury, you're not with your family, you're not in your normal area. Of course you're having sleep problems. So the sleep issues tend to get attributed to that rather than something that is going to stick around. So being able to know that that is a potential and be mindful of watching for that potential of that continuous sleep-wake disturbance is really important. Another one we published was, we knew it was more common in the ischemic stroke patients. So we took those ischemic stroke patients and divided them up by injury location. Now we couldn't be super specific, right? Since brain injuries are so unbelievably different. No injury is exactly alike. So we have to kind of group the injuries in kind of large areas. And the way that we did that were injuries that were supratentorial, which basically means above the tentorium in the brain, which is like the cortex. So kind of this part of the brain here. And then infratentorial, or below the tentorium, which is going to be kind of this lower part here. So under like the cerebellum brainstem type area, okay? So that's how we divided it up, supratentorial and infratentorial, based on kind of the top part of the brain or the lower part of the brain. And what we found here was pretty interesting is that when we looked at sleep efficiency, is this first graph here, sleep efficiency. So the amount of time that they're actually sleeping is better in the supratentorial injuries. So if the injury happens kind of in the top forward part of the brain, it's better. The sleep efficiency is much better than in the infratentorial, right? The next one When we specifically looked at REM sleep, which tends to be associated with learning and memory, so our cognition, our big parts of our daily living are required. We need that learning and memory, that cognitive ability to be able to function normally during the day. So when we looked at the REM sleep duration, those infratentorial or the lower injuries had way less REM sleep, significantly less REM sleep. We broke that up further in how long was the longest period of time that they were in REM. So not just a gross percentage of the entire time. So for 8 hours, they had 15% of REM. We wanted to look at what was the longest period of time that they were in REM sleep. Was it 5 minutes? Was it 90 minutes? Was it 30 minutes? And what we found was that the longest REM periods were longer in the supratentorial patients, so that top part. So again, the infratentorial patients did significantly worse on that, and that corresponded to lower cognitive scores, to lower subjective quality of life. So we know that it is likely impacting those things during rehabilitation. We did some TBI research as well. We actually have this paper published. I didn't have time, didn't realize that I hadn't switched it out to the paper itself, but this is a poster that we had presented on that for the TBI. So some highlights of this are, again, looking at what that sleep architecture looks like, and that 67% of patients had less slow wave sleep than what we call age norms. So patients that, or people that did not have a brain injury at the same exact age, how much percent slow wave sleep did they have versus our brain injury patients? And 67% of our TBI patients had less slow wave sleep. So it impacted it big time. Also, almost 30% of the patients had less than 1% of slow wave sleep. So again, almost non-existent, not just less than our age norms, but almost non-existent. And this is, again, that deep restorative part of sleep where we're kind of getting rid of the junk that we don't need to learn during the day, the stuff that wasn't as important. We're really getting that rest, lots of complex things going on at the time, and we're almost getting none of it in those TBI patients. This was also significantly correlated with quality of life. So those patients that had less slow wave sleep are scoring worse on subjective quality of life measures. So their ability to participate in social roles and activities, their satisfaction with social roles and activities, and their subjective sleep disturbance. So those patients that had less slow wave sleep kind of noticed more that they weren't sleeping well than any of the other patients. Something else was that impact of REM sleep on cognition. So we have what's called the California Verbal Learning Test. Some of you may have done that before, but you're essentially supposed to remember a list of words that the therapist is going to read off to you. They read them 5 separate times, and you remember as many as you can, as quickly as you can, and then they give you another list. And then you're supposed to remember that new list instead of the old list that they just read 5 times, right? So what that does is it tells us how we can learn and remember, but it also tells us if interference is a problem. So if some new information comes in, are we still able to remember the old information? And our patients that had more REM sleep did much better on that cognitive test. And again, so what we see in this part of the poster here is the impact that sex has on our REM sleep. So women essentially are having less of the REM sleep, and that's kind of coming through in their subjective quality of life, that they're reporting lower levels of subjective quality of life. So given that sex differences in REM exist and the association between REM sleep and behavior, it's likely that those sex differences are impacting or contributing to outcome potential. So we need to be especially cognizant of this for our female patients. All right, so the secondary impacts, I said at the very beginning, I wanted to talk about a couple other things that might contribute to sleep-wake disturbances or vice versa. So usually, one of my favorite presentations that I give is on secondary or under-recognized comorbidities of brain injury, the ones that are impacting pretty much everything, impact each other, but tend to go under-recognized in a clinical setting. So sleep is one of them. And the next one is neuroendocrine dysfunction or hormone imbalances, right? So many hormones are produced during or are regulated by different stages of sleep. So for example, our thyroid hormones decline as the night progresses. Cortisol or stress hormone rises during the night, kind of peaks right when we wake up. Sex hormones are produced during slow wave sleep. Growth hormone is produced in slow wave sleep. So if we consider the rest of the presentation that I just gave on having a brain injury, having sleep architecture disrupted, having almost non-existent slow wave sleep, it's kind of maybe intuitive to see that if your sleep is disrupted, it's likely that your hormones are also disrupted, and vice versa. If you have a hormone imbalance, it's likely that because they're regulating stages of sleep, those are part of the signals that are given to tell our brain to go into different stages of sleep. If our hormones are imbalanced, it's likely that that is impacting sleep as well. Now, why is this important? Our hormones pretty much signal everything in our body to do different things, and our brain is responsible for sending those signals, right? So the brain is going to be sending signals to the pituitary is sending, or other parts of the brain are sending it to the pituitary is sending it to all of our vital organs, our bones, our muscles, our skin, our thyroid, our sex organs, our kidneys. Everything is getting these signals for the hormones. So again, if our brain is not telling our hormones what to do properly, or there's some sort of imbalance, then that's going to lead to all of these secondary effects like decreases in energy, issues with mood and energy and stress, with muscle mass, with memory, anxiety, depression, attention, pretty much everything. So again, we have these overlapping symptoms with hormone imbalance and sleep disruption. And brain injury itself, right? What are the symptoms of brain injury? Cognitive dysfunction, emotional behavioral issues, fatigue. What are the symptoms of sleep issues? Cognitive dysfunction, emotional behavioral issues, fatigue. Hormones, same thing. So they overlap with each other, which makes it hard to identify when one is a problem. They may be attributed to the brain injury itself rather than a secondary issue that can be treated. And they also impact each other, which makes it difficult, because if you are treating one without treating the other, it's kind of like we're sticking a piece of duct tape on a hole in a sinking ship, right? We're never truly going to fix the issues if we're not addressing all of them at the same time. The other one that I want to mention is the gut microbiome, our gut microbiome, gut health. Right. So this is the other one that it tends to be that under-recognized comorbidity. I like to talk about it with sleep and hormone dysfunction because, again, what are the symptoms of gut microbiome dysfunction or our gut health not being great? Cognitive dysfunction, emotional behavioral issues, fatigue. And if your gut health is not healthy, then it's going to lead to issues with brain health. There's a direct connection there. It's going to lead to issues with sleep because of the neurotransmitters that the gut is responsible for kind of producing by way of amino acids. And really, if we want to talk about exactly what the gut microbiome is, right, it's this balance of gut bacteria that we have that performs functions that are critical to health and well-being. Some of the expected things that it does maybe are digesting food, absorbing nutrients, but really unexpectedly, I think it's becoming more wide or mainstream. I think that gut health is so important, but 5 to 10 years ago, not really at all. So it was pretty unexpected that gut health contributed to our immune system, to our mood, and to brain function as well. Again, each person has a very unique balance of gut bacteria. It's influenced heavily by genetics, by our environment. So typically, people that grow up in different geographical locations are not going to have the same balance of gut bacteria, right? Because they're eating different foods, they're drinking different water, they're around different environmental toxins. So it's really variable between individuals. But the function of that gut bacteria and what we're doing and how that contributes to brain health can really be boiled down to the role of amino acids, right? So amino acids are crucial to function, and we can divide them into two different categories: essential and non-essential amino acids. Essential amino acids are ones that we ingest through food, while non-essential amino acids are synthesized on their own in our body. So the essential amino acids we have to get from food that we're eating in the environment. The non-essential ones, again, are normally produced. It's kind of a misnomer because they are indeed essential, but they're non-essential in that we produce them and we don't have to get them from anywhere else, right? But these amino acids are the building blocks of proteins. They help produce hormones and neurotransmitters. And there is a direct connection from the gut to the brain via the vagus nerve, right? So what's going on with our gut and the balance of the bacteria that is there significantly contributes to how our brain functions and vice versa. Okay, so there's a lot of research that is available now that tells us that a healthy gut contributes to good sleep, and good sleep contributes to a healthy gut by way of that direct connection. Also because of kind of secondary effects on the immune system. So again, if one is unhealthy, it's likely that the other is going to be unhealthy as well. And this disruption of that balance of gut bacteria is so important in TBI because we've shown that those amino acids are imbalanced in chronic traumatic brain injury patients. That the amino acids that are supposed to be contributing to good, healthy sleep are very, very low or non-existent in chronic TBI patients. That balance is extremely off. So what this gives us essentially is the ability to see traumatic brain injury as a chronic disease process, not a single injury event. Something that it gives us an avenue for an extra thing that we can identify, know it's a problem, and treat it. When it comes to, I get this question all the time where they're like, well, can't we just, eat a whole bunch of healthy food? Well, yes, if our gut was absorbing the nutrients properly. And in chronic traumatic brain injury, what we've found is that that's not happening, right? So when our chronic TBI patients are eating all of those healthy foods rich in amino acids, instead of the body absorbing them like they should, it's coming straight out in the fecal matter. So all of that healthy stuff is coming out rather than being absorbed. So it almost wouldn't matter how much healthy food they got because their bodies aren't absorbing it. So what we need to do is work on how do we fix that balance of gut bacteria so that they do absorb those nutrients from the healthy food. So things like prebiotics, probiotics, where we're establishing that healthy gut bacteria, that balance of gut bacteria back is where research is headed now. How do we balance what became unbalanced, right? So bouncing back to the sleep-wake disturbances, what do we do? How do we screen for those? How can you screen for them? What can we do in the physician's offices? Typically, your physician's going to do a clinical interview. This is really good for establishing like starter information what was your sleep like before your injury versus what is your sleep like now, right? So we can get that kind of comparison there. Sleep diaries also, if you have them or have started them, wonderful. If not, and you are having sleep difficulties, I suggest doing a sleep diary. It's really useful for monitoring those sleep wake disturbances, because a physician could ask you like, oh, well, how have you been sleeping? And it's, oh, well, I sleep terrible, or I sleep fine, either way. And then once you actually start writing it down every day, you can actually look at that over time and say, oh, well, maybe it's not as bad as I thought, or, ooh, maybe that is, just as bad if I thought, or worse than I thought. So it's really good for identifying how those changes are happening, and keeping record of it. Self-report questionnaires are undoubtedly always going to be used. Things like the Epworth Sleepiness Scale or the Pittsburgh Sleep Quality Index are ones that are used very frequently. I don't particularly like at least the Epworth. In acute settings, the patients tend to underreport some of their sleep-wake disturbances, and I think that's just because there's so many other things going on that sleep is kind of the last thing that they're thinking about. So at least in acute settings, maybe not the best time to do those, but definitely later on can be useful. And they're very, very easy and quick to do. You could even just do them on your own at home. You can find what the Epworth looks like online. It's basically a list of scenarios, and you just say on a scale of 0 to 3 how likely you are to fall asleep. So after lunch, sitting quietly by yourself, driving a car, and you just rate them. And then the score you get at the end tells you how sleepy you are and could be considered that excessive daytime sleepiness. That's one of those prerequisites, right, for a sleep study. Now, objective measures should be used whenever possible. So those sleep diaries, clinical interviews, the self-report questionnaires are good for like a baseline starter information, but those objective measures are great whenever it's feasible. The polysomnographies are going to be your gold standard. That's that in-lab, overnight, hooked up to all of the stuff test. Home sleep tests are a second runner-up, but they are only going to test for sleep apnea. You can get some now that are fancy and will do restless leg, but they're not great at that, and there's not that many of them that do that. Essentially, it's only testing for sleep apnea. And if your sleep apnea, or if your home sleep test comes back negative, it doesn't mean that you don't have sleep wake disturbances. It just means that you might not have sleep apnea, right? So all those other things that we talked about, REM sleep behavior disorder, restless leg, the sleep architecture being disrupted, that's going to contribute to other things. Any of those things could be wrong, and the home sleep test is not going to tell you yes or no. Actigraphy can be used, is really good in conjunction, so at the same time as a PSG. So the PSG, again, is that overnight sleep study. So if you're wearing a Fitbit or you have an Oura Ring or some other sort of activity monitor, having the data from that and being able to compare it to what happens in your overnight sleep study can tell you if you slept really different, like maybe not as much as you normally do during that overnight sleep study. And that can be really useful for a physician that's looking at that sleep test. As far as treatment, the tried and true, it will fix it way to fix sleep apnea is that CPAP or BiPAP. We all hate them, right? But if you wear them, they will treat your sleep apnea and you will feel better. I promise. The masks are not as bad as they used to be, right? So I feel like patients now hear sleep apnea or hear sleep-wake disturbances. They think sleep apnea. They think, I'm going to have to wear a CPAP. And they're like, I'm not going to have a sleep test because I don't want this giant octopus on my face. But technology has gotten way better. They have ones that'll sit directly under your nose. It's just a nasal pillow. They have some that cover the whole nose but leave the mouth open. They have some that sit under the nose and cover the mouth. It's like a hybrid type of mask. All over the place. They have a whole bunch of different kinds, and you can try as many as you want with CPAPs and BiPAPs, but if you can get compliant, you will feel better, not only functionally, but psychologically as well. So a lot of decreases in the depression and anxiety have happened because of patients being compliant and using their CPAPs. Pharmacological treatment, if it's not sleep apnea, what do we do then? There is some overlap with treatment for other disorders, but if we're using medication for sleep, like a melatonin or anything else, it's ideally used short term and then should be paired with good sleep hygiene. So not something that we just want to be reliant on and using all the time, something that we kind of use in the interim until we can help our brains figure out how to sleep well again. And we can also work on some behavioral modifications like sleep hygiene. So what is sleep hygiene? So again, if you do not have sleep apnea, sleep hygiene is a good way to start. If you have sleep apnea, no amount of good sleep hygiene will fix your sleep apnea. Okay, you could do all of these nice sleep hygiene things and it will not fix your sleep apnea. But what can we do for that behavioral modification? Limiting daytime naps, because what happens when we take naps during the day, right? We're tired in the morning, so we take a nap and then we go to sleep at night. And we took a nap, so now we're not tired, and then we can't sleep at night, so we're tired in the morning. So we really need to be careful to limit those daytime naps and also exposure to natural light when possible. So kind of waking up in the morning, opening up those curtains, getting that sunlight, getting outside as much as possible so that your brain can adjust to those normal signals that it receives from sunlight, right? That circadian rhythm. A lot of consistency helps, going to bed and waking up at the same time every day, even on the weekends. So even if you don't have to go to rehab at 8 a.m. on Saturday, still waking up at your normal time on Saturday can be really, really beneficial. Again, especially until you can kind of reset what's going on with your brain. Relaxation techniques, meditation, deep breathing has been very, very helpful for some patients. And then, TV. I know a lot of us like to watch TV before we go to bed, but just that exposure to blue light can significantly impact your ability to fall asleep. It kind of disrupts the production of melatonin, that hormone that's going to help us go to sleep and signal sleep, avoiding caffeine and things like that. Something else that's really helpful is if you find yourself in bed not being able to sleep, do not stay in bed and toss and turn and stay awake in bed. If you can't fall asleep, get out of bed, read a book, listen to music, do whatever, to go take a hot bath, something like that to relax, and then go back to bed and try again.